The newborn assessment is the foundation of all newborn nursing care. The neonatal period lasts for the first 28 days of life. This is the period of the most dramatic physiologic change in a human's life. An awareness of expected findings and normal variations for a newborn is crucial to identifying possible problems and providing required nursing interventions. The newborn must make rapid respiratory and circulatory changes to transition to extrauterine life. It is most important to understand that respiratory function is established when the umbilical cord is cut and clamped. When this happens, air inflates the lungs with the first breath and pushes amniotic fluid out of the alveoli. This first inflation of the lungs dramatically decreases the pressure and resistance to blood flow in the lungs. This low pressure allows blood to enter the lungs for the first time. Circulatory changes also occur due to the changes in pressure after the umbilical cord is cut and the newborn begins breathing. Fetuses have three shunts: foramen ovale, ductus arteriosus, and ductus venosus, that are required for fetal circulation. These shunts are no longer needed and close during the newborn's transition period. Since the three shunts are normal findings in the fetus, it is impossible to predict whether they will close normally after birth. These bypass pathways in the fetal circulation make it possible for most fetuses to survive pregnancy even when there are complex heart problems and not be affected until after birth when these pathways begin to close. This is a great video that shows a newborn circulation right after birth. The Khan Academy also has another video that explains fetal circulation, which is interesting but more complex than what is expected for a new nurse to understand. I really like this chart that breaks down the differences in a fetus versus a newborn. I want you to focus on the newborn column, understanding how the newborn's respiratory and circulatory systems help them transition and sustain life outside the uterus. The initial newborn assessment is quick with the goal of identifying life-threatening abnormalities and respiratory distress. Possible problems the nurse will observe that require immediate intervention include nasal flaring, chest retractions, grunting, apneic episodes greater than 15 seconds, abnormal respiratory rate, either greater than 60 breaths per minute or less than 30 breaths per minute, abnormal heart rate, either greater than 160 beats per minute or less than 100 beats per minute, flaccid body posture, and generalized or circummoral cyanosis. APGAR scoring provides a quick nursing assessment and evaluation of how the newborn is adapting to extrauterine life. An APGAR score is given at 1 minute of life and 5 minutes of life. The newborn will be closely monitored in the first 2 hours after birth. During the first couple of hours after birth, the labor nurse will weigh the newborn on a scale or panda warmer and measure the newborn's length and head circumference with a paper tape measure. If the newborn's head appears smaller than the chest, it is important to measure a chest circumference as well. When documenting a newborn's weight, the nurse will document normally in kilograms or grams. However, when we announce the newborn's weight to the family, nurses normally convert the weight to pounds. Remember that 2.2 pounds equals 1 kilogram equals 1,000 grams. Gestational age assessment classifies the newborn by gestational age and birth weight. Gestational age is the same as weeks gestation, such as 38 and 3, which we also say 38 and 3/7. Gestational age assessment is important because it allows the nurse to plot growth parameters and to anticipate possible problems related to a newborn being SGA, LGA, preterm, late preterm, or postterm. Here is an example of a growth chart. A nurse will plot the newborn's weight and weeks gestation to determine the newborn's percentile. If a newborn falls between the 10th percentile and the 90th percentile, the newborn's gestational age assessment is categorized as AGA, average for gestational age. If the newborn's weight is less than the 10th percentile, the newborn is categorized as SGA, small for gestational age. If the newborn's weight is greater than the 90th percentile, the newborn is categorized as LGA, large for gestational age. An example of the importance of accurate gestational age assessment is determining the newborns at risk for hypoglycemia and thermoregulation. Newborns that are SGA or LGA are likely to have issues regulating their blood sugar and body temperature. A nurse responsible for caring for neonates must know normal ranges for vital signs. Newborns do not have a regular respiration rate. They have a normal respiration rate, which is between 30 and 60 breaths per minute. However, neonates commonly breathe in an irregular pattern, and we consider this normal. They use their entire abdomen to breathe. It is common to have short periods of apnea lasting less than 15 seconds. When assessing the heart rate, the nurse must listen to the apical heart rate for 1 full minute. When assessing temperature, always do an auxiliary temperature on a newborn unless a specific order is given by a physician. Knowing your normal ranges help to assess when vitals are abnormal and nursing interventions are needed. Cord blood is collected at birth from the umbilical cord. It is collected on all newborns if the mom is blood type O, meaning O positive or O negative, or if the RH is negative, so A negative, B negative, AB negative. The collected cord blood is sent to the lab to determine the newborn's ABO blood type and RH status. Cord blood is not sent if mom is blood type A positive, B positive, or AB positive, because there is a low risk of complications. Other labs that may need to be drawn on a newborn include a CBC, total bilirubin, retic count. These labs are by pediatrician order or hospital policy. We will also monitor blood sugar glucose on newborns at risk for hypoglycemia, but we will use a heel stick and glucometer at the bedside. It is important to know the expected lab values for newborns. Any critical value needs to be reported to the pediatrician within 30 minutes. A head-to-toe newborn assessment. I'm going to discuss how to perform a comprehensive assessment of a full-term, average for gestational age newborn. When we discuss newborn complications, we will discuss the differences expected in late preterm, postterm, SGA, and LGA newborns. For today, we are going to focus on the full-term AGA newborn. I encourage you to watch this newborn head-to-toe assessment video. This video is about 20 minutes long, but it is almost exactly how I perform a newborn assessment. There is an initial newborn assessment video under our videos section in Moodle. The initial newborn assessment video is comprehensive and is about an hour long. It does a great job of of explaining how to do assessments and why. My first step in performing a newborn assessment is to do a visual surveillance of the baby first. First, I am observing the newborn's posture and expect to see the newborn in a flexed, curled up position with their arms and legs in moderate flexion. The newborns on the left and in the middle picture have a normal resting posture with loosely clenched fists and abducted arms, hips, and knees. The baby in the picture on the right was a breech baby. A nurse can tell by the fully flexed hips and knees. The skin assessment is part of the initial visual surveillance of the newborn. I expect newborn skin to be pinkish red, congruent with their genetic background. It is normal for a newborn to turn redder when they cry. The newborn skin will be dry and peeling cracks can be present around the hands and feet. The third picture shows a newborn with vernix, a thick white cheesy like protective covering. All fetuses are covered in vernix. The closer a newborn is to full term, the less vernix will be present. A preterm newborn usually has very abundant vernix. The picture of the way all the way to the right shows a newborn with lanugo, a fine downy hair. Lanugo is also more abundant if preterm and is usually found on the ears, forehead, and the shoulders. The newborn's hands and feet may appear bluish purple and even feel cool. This is called acrocyanosis and is considered a normal variation in the first 24 to 48 hours of life. You can see typical acrocyanosis in the first picture. Educate parents that acrocyanosis is expected and will resolve as the newborn's circulation increases. The second picture shows milia. Milia are tiny white spots on the nose, chin, or forehead. Milia will disappear all by themselves. It is important to educate parents to not squeeze or try to pop the milia spots. Mongolian spots, more appropriately called congenital dermal melanocytosis or slate gray nevi, are flat congenital birthmarks that have increased pigmentation and appear dark bluish gray. They are usually located on the buttocks and lower back. It is the nurse's responsibility to educate parents on the presence and also document the location. The first picture shows a stork bite. These nevi are flat, pinkish red marks that blanch easily. Stork bites are commonly found on the forehead, upper eyelids, neck, and nose, and usually disappear by age 2. The second picture shows a newborn with a port wine stain, and these are less common. The third picture shows erythema toxicum, known as a newborn rash. A newborn rash appears as a pink rash that suddenly appears on the body. This is not a true rash. It is the newborn's skin reacting to all the new things it is touching, like mom's skin, clothes, and blankets. No treatment is required and does not bother the newborn at all. On to head. As we start to now put our hands on the newborn, we are going to assess literally from head to toe. We need to look at the newborn's head shape, taking into consideration if they are a vaginal delivery or a C-section delivery. When thinking about assessing a newborn, remember you will be assessing for expected findings, normal variations, and possible problems. Expected findings for a newborn's head would be a round head with a soft and flat anterior fontanelle and palpable sutures. Some normal variations include molding, to allow the newborn's head to fit through the vaginal canal, and separated or overriding sutures. Possible problems include microcephaly, which is a small head, sunken fontanels, which means dehydration, bulging fontanels, which means intracranial pressure, or fused sutures. The picture on the left shows normal molding. The picture on the right shows overriding sutures, which feel like ridges. Two other normal variations are caput and cephalohematoma. A caput is localized swelling of the soft tissues of the scalp caused by normal pressure on the head during labor. Caput feels like a soft adenomous mass and can cross over suture lines. Caput usually resolves in 3 to 4 days by itself and no treatment is required. A cephalohematoma is a collection of blood between the periosteum and the skull bone. A cephalohematoma does not cross the suture lines and results from trauma during birth, such as prolonged pushing or a vacuum delivery. A nurse needs to know the differences between caput and cephalohematoma. A newborn with a hematoma, a collection of blood, is at higher risk for jaundice. When assessing a newborn's eyes, they should be symmetrical in size and shape and have no drainage present. A newborn's eye color is usually slate blue or dark brown. Eye color normally changes to permanent eye color around 12 weeks old. A newborn may have random, jerky eye movements or cross their eyes. This is a normal variation from the lack of muscle control to regulate eye movements. It will resolve as the eye muscles strengthen. The nurse will assess for presence and correct placement of ears. To assess placement of ears, draw a line with your finger from the inner to the outer canthus of the eye to the ear. The line should be even with the top notch of the newborn's ear, where the ear meets the scalp. Low set ears is a normal variation and can indicate a chromosome abnormality. For the full-term newborn, ear cartilage should be firm and well formed. A nurse also inspects for skin tags on the ears. Ears and kidneys form at the same time in utero, so there could be a possible kidney problem if skin tags are present on the newborn's ears. A newborn's nose should be midline, flat, and broad. There should be no drainage present. Newborns are obligatory nose breathers, which means they only breathe through their noses until about 3 months of age. A nasal blockage can result in nasal flaring, cyanosis, or asphyxia, which are possible problems. Newborns sneeze to remove amniotic fluid from their sinus canals. This is normal, and the body's response to rid itself of fluid it no longer needs. Make sure to educate caregivers that sneezing is normal and the body is responding appropriately. The nurse assesses the newborn's lips and mouth. Expected findings are pink color, moist membranes, and symmetrical. The hard and soft palate should be intact, assessed when eliciting the suck reflex. A newborn may develop a sucking blister from a bad latch. This is a normal variation, not a problem with the newborn. However, the latch does need to be observed during the next breastfeeding to assess for any issues. The mucous membrane should be moist, but saliva should be scant, as excessive saliva is a possible problem. Some other findings that are normal variation a nurse may assess when inspecting a newborn's mouth are Epstein's pearls, which are whitish yellow cysts found on the gums and palates of the newborn, and a precocious tooth, which is a tooth present at birth. A precocious tooth can be a possible problem if it is loose, as it may fall out and the newborn could swallow it. When assessing a newborn's neck, the nurse expects the neck to be short, thick, surrounded by skin folds, and have no webbing. Normal variations can be found with a lack of head control, normally related to prematurity or Down syndrome. For the newborn's chest assessment, the nurse expects to find a barrel-shaped chest, clavicles intact, respirations are diaphragmatic, using the diaphragm and whole abdomen. No retractions are present, and nipples are present and symmetrical. A newborn's abdomen should be round, soft, dome-shaped, and non-distended. Bowel sounds should be present within a few minutes following birth. The nurse should also assess the umbilical cord, observing whether the cord is moist or dry, clamped, or if the clamp has been removed. The nurse pays close attention to the voiding and stooling patterns of a newborn. All newborns are expected to void and stool at least one time in the first 24 hours of life. A lack of urine or stool after 24 hours may indicate a possible problem. Uric crystals can leave a rust-colored residue in a newborn's diaper in the first couple of days of life. This is an expected finding. However, the nurse needs to educate caregivers about this expected finding because uric crystals are mistaken for blood by caregivers. For newborn boys, the scrotum should have rugae, testes should be palpable in the scrotum, and the urinary meatus should be located at the penile tip. For newborn girls, the labia majora should cover the labia minora and can appear edematous due to the mother's hormones. Pseudomenstruation is a normal variation of blood-tinged discharge from the newborn's vagina. When assessing a newborn's extremities, the nurse will assess for 10 fingers, 10 toes, range of motion, normal flexion, symmetrical gluteal folds, well-creased soles of feet and palms of hands. Extra digits is a normal variation. Possible problems include asymmetrical gluteal folds. Flip the newborn over to assess their spine. The spine should be straight, flat, midline, and easily flexed. Possible problems include a deep sacral dimple, unable to visualize the base, and hair tufts, which can indicate spinal bifida. With each assessment, the nurse needs to assess pain using a combination of behavioral observation and physiological findings. Pain scales such as NPAS or NIPS are used to assess pain in a newborn. Physiologic responses to pain include inconsolable crying and vital sign changes. Newborn reflexes affirm that a newborn's cognitive development is normal. When a newborn reflex is present, this is a positive sign that the central nervous system developed normally. Sucking, rooting, palmar grasp, plantar grasp, the Moro reflex, tonic neck, Babinski, and stepping reflexes are the most assessed newborn reflexes. Please know how to elicit each reflex during a newborn assessment and the expected finding. I have included videos to help you visualize how to elicit the newborn reflexes. Please watch this great and quick video showing you how to elicit the main newborn reflexes. The nurse elicits the sucking reflex by placing a gloved finger in the newborn's mouth. The newborn should begin sucking. This is also the best time to assess the newborn's suck. Is it strong, weak, coordinated, uncoordinated? The rooting reflex is elicited by stroking the cheek or edge of the newborn's mouth. The newborn should turn their head toward the side that is being touched. The palmar grasp is elicited by placing a finger in the palm of the newborn's hand. The expected finding is for the newborn to curl their fingers around the nurse's finger. To elicit the plantar grasp, the nurse places their finger at the base of the newborn's toes. The expected finding is for the newborn to curl their toes downward. To elicit the moral reflex or startle reflex, the nurse allows the head and trunk of the newborn to fall backward slightly. The newborn will extend their arms and spread their fingers to form a C. The tonic neck reflex is elicited by laying the newborn on their back, turning the newborn's head quickly and gently to one side. The newborn's arm and leg on that side will extend, and the opposing arm and leg will flex. The Babinski reflex is elicited by the nurse gently stroking the outer edge of the sole of the newborn's foot, moving up toward the toes. The newborn will fan their toes upward and out. The nurse elicits the stepping reflex by holding the newborn upright with feet touching a flat surface. The newborn responds by stepping movements.